Hello, everyone. Good afternoon. Welcome to our Friday noon seminar series. Today, we have the pleasure of welcoming Dr. Christina Tsien. She's a radiation oncologist here at the McGill University Health Center. I actually don't know her background, and I don't want to guess, but I know you did your MD at McGill, correct?
Yes.
Yeah.
Residency too.
Residency too. Then you were in the US for a while doing fellowships, working at a Proton Center in Johns Hopkins.
Yes, I was a Proton director at Johns Hopkins, and I worked at Washington University, heading their gamma knife and neuro-oncology program. And I was spent really my career at University of Michigan, where I was professor in radiation oncology.
And you've since returned back to Montreal in 2022, and you've been here since. And we don't have protons here, but Dr. Tsien will tell us all about how they work and what they do. So with that, I'll hand it to you, Dr. Tsien.
Okay, so thanks, Pete, for the nice invitation and welcome. So basically, again, due to cost and building space and manpower requirements, proton therapy is confined only to a few centers, and patient access remains limited. So there's been an exponential increase in proton facilities, with now over 100 proton centers that are online, operational worldwide, and the majority have really opened most recently in the last decade. And unfortunately, Canada remains the only G8 country that doesn't have its own proton center. But this is about to change, which is really the purpose of this talk. So the first Canadian center has now been announced. It will be in Edmonton. And again, my goal here today is to provide a clinical argument for protons. So I just wanted to share a little bit of just what the kind of, each center has its own, I'll call it proton patient distribution. And again, as you see, there's typically a clear indication for treatment of pediatric patients, again, to reduce late toxicity and also risk of second malignancy. But you can see really that there is a wide variety of tumors that may benefit from protons. And in adults, it's mainly confined to both CNS and head and neck, and motion management and recent technical advances in being able to manage motion has really increased its huge impact on other types of tumors, including breast, lung cancer, esophagus cancer, sarcomas, etc. So why proton therapy? Again, it has its particular, don't have to tell this audience, physical advantages of charged particles, again, by depositing its radiation dose to a clearly defined target region. And this minimal or no exit dose beyond the specified depth or the Bragg peak really causes less damage for tumors that are adjacent to a critical, healthy, normal structure. So again, it's important to emphasize that there are also biological advantages. Again, protons can cause a complex DNA damage that is more difficult to repair, and therefore it can allow us to dose escalate very treatment-resistant type tumors that are in critical locations. And I'll just show you some examples. But now with significant imaging and improved technology, it may help us to be able to deliver fewer number of fractions, making this much more feasible for more patients, and also increasing tolerability of the treatments that we currently give, so that a lot of patients receive concurrent chemoradiation with significant toxicity. And now there's a significant interest in combining radiation with novel treatments like immunotherapy, and radiation causes quite a lot of immunosuppression and reduces its impact. So again, I'm just going to share with you a few slides. Just this is an example of a head and neck cell line. So these are HPV positive cell lines. And we do seem to see that there are more complex and clustered DNA damage that occurs compared to photons. And that we see on the right, again, this increased mitotic catastrophe and senescence that is seen. These are HPV positive cell lines. And so there's a potential of combination with novel therapies, including DNA damage repair pathways, such as PARP inhibitors, that can really lead to a synergistic effect. So this is just a quick slide looking at proteomics analysis of proton expression. Again, in protons compared to photons in both head and neck these are HPV positive and negative cell lines, we see that protons induce a higher protein expression in both DNA repair pathways, cell cycle arrest, and even immune responses. So again, highlighting areas where potential synergy between protons and systemic therapy. Again, just as a reminder to this group, it's not, protons are definitely not new technology. Again, with their prohibitive, expensive price tag initially, the first hospital-based proton program was really opened not until 1990 at Loma Linda. And that's really took 35 years from the initial discovery by Wilson. And it took another decade for the three kind of, I'll say, champion hospitals to open their centers. So that includes the Boston MGH, MD Anderson, and University of Florida. So again, despite the new proton centers, there's been a substantial improvement in technology. In fact, spot scanning, as this group is aware, was not really available until it was first used at PSI in 1996. So we've only really recently have been only able to exploit the benefit of proton therapy. There's a significant learning curve, and I think that's very clear for most new institutions. And it's really important to know that most of the published proton data that we see that is out there really is comparing a very robust, mature IMRT results with very, very early results from proton therapy. So again, this really just kind of highlights that most of the papers that are published are really based on passive scattering. Again, this proton charged accelerators produce this very narrow proton beam, and that this needs to, in order to provide a appropriate treatment field, it needs to be scattered either with a foil or scanned. And this scanning beam really allows us to take the full advantage of proton therapy by delivering the treatment layer upon layer by each beam energy and really providing an optimal dose distribution or 3D painting of the tumor. And this really has provided a significant advantage in achieving dose constraints that cannot be achieved with standard passive scattering techniques. So again, really just as a reminder, it's only these kind of new centers that have opened that really have the full capabilities, that have a rotating gantry, at least to provide improved treatment plans, a robotic couch to really improve the patient setup, and really onboard imaging is still something only unique to a portion of functioning proton centers, with the capability of things that are really standard on any LINAC with cone beam CT and optical surface imaging to really improve the, to reduce the uncertainty of the proton treatments, to ensure that we're really treating the target because of the critical location where we're delivering. So again, being able to do imaging and gating, especially for patients with significant motion management, all of these kind of techniques are really important to improve the safety of the proton delivery. So this is really just an example showcasing just the imaging that is feasible. Certainly in areas like the abdomen are really crucial and important to ensure that the treatment is delivered at the right area. So again, the key thing is that we all know that protons are very expensive. And the question is it actually in a socialized government where funding is very limited, can it be cost effective? And I think there are two important things to remember. One is that the life expectancy of a cyclotron is much longer. So many times we're replacing LINACs every 10 or 12 years. And again, life of a proton kind of treatment machine can be double that or much longer. And so it's very important to consider amortizing costs over this long-term use. And by doing that, proton therapy can be considered cost neutral. I'm going to give you an example. Really, when you factor in the cost of taking care of all of the secondary malignancies and additional treatments that are required, including surgeries and hospitalizations with conventional treatment. And the increased use of hypofractionation are really going to be very important also in kind of narrowing that playing field. So again, just as a kind of quick summary in terms of patient selection, it's really important to understand that protons is not the optimal treatment for the majority of patients, and that it does not eliminate radiation-associated side effects. So again, the most common indication is typically curative pediatric cases, where it can be deemed cost-effective, especially in young patients where the risk of secondary malignancy or long-term toxicity is very high. But it can also occur in adults where it can be considered cost-effective, where in some cases treatments have been considered to perhaps improve overall survival. I just want to give an example of prostate therapy, which is probably the most common use in the United States, where a recent SEER analysis, again, this is based on Medicare data, and this was data from 2010 to 2017. And I think that, again, it's very important to highlight that even though in these papers that they show no difference in GU and GI toxicity, we really rely on the ongoing and most recently completed patient-reported outcomes and clinical trials to be able to show these differences. Again, with these Medicare SEER data, there are a lot of assumptions, and it is with all of this changing technology, it is possible that many of these proton plans actually can increase the toxicity. So again, other areas that have been shown to be of benefit, and I'll show you some examples, they including head and neck cancers, skull base, tumors that occur in very critical areas that can really significantly improve the patient's quality of life and reduce their long-term risks of long-term side effects. So again, here's an example in a pediatric case where we're looking at upfront costs, where we know that proton therapy is higher. But it's really important to emphasize that the expense of managing complications with multiple surgeries and hospitalizations, as well as the loss of function of patients, meaning their inability to return to work, their inability to contribute to society, is a significant social expense. So again, I just want to highlight in a couple of slides, again, it's really important to know that in places where protons are available, it is still quite limited to patients. And this is the reason why is that insurance companies, again, are putting a high bar, and that patients, physicians and patients have to show that there is a probability of a clinical, meaningful benefit in terms of whether a proton plan that can achieve a critical dose constraint that cannot be achieved with photons, and that there would be a clinical benefit to the patient. It's not just a kind of DVH difference. And these are all challenges that make the cancer therapy for patients much more challenging. And I really suggest that those who are on this stream, that there are many advantages with AI and technologies to really improve this workflow or process for patients. So again, just as a summary of the most common toxicities that are most common indications, they are clearly ocular tumors with intraocular melanomas, are chordomas, and skull base tumors, and even spine tumors where the spinal cord tolerance and patients with genetic syndromes, and not limited to NF1, and reirradiation cases are probably the most kind of common indications. But in terms of patients receiving proton therapy, again, there are many patients with including head and neck cancers, lung cancers, esophagus, hematologic malignancies, including lymphoma, again, for curative intent, and prostate cancer, and as well as left-sided breast cancer. And these require that there is a potential benefit in clinical significance, or that patients are on a clinical trial, or that they are involved in a patient registry. And again, these are all important for us as a group, including our physics and physician colleagues, to really be able to help us to create, I'll call it this library or knowledge-based, I'll call it planning, or that can really help improve the efficiency, so that in a patient that you're seeing in your clinic, that you can simply by looking at their diagnostic imaging can match this with a proton DBH or proton kind of similar location, a plan that can show what the potential benefits are in terms of dose response, in terms of tumor control, but also in terms of toxicity. So again, this ability to find a similar plan or else in terms of creating plans. And I think that with all of this new AI and this ability to look at thousands and thousands of cases, that we won't need this ability to recreate the wheel for every single patient that comes into our clinic. So again, very important information that is required, including not only being able to calculate what the patient actually received, so the cumulative dose that the patient received throughout their course of proton therapy, and be able to have this in a DICOM format, and to be able to capture all of the DBH information. And as we do here in our clinics, being able to provide summaries of what these dose constraints and whether they are met are really important for us to show the improvement of proton therapy in a kind of socialized environment. So again, I'm just going to show some very classic examples and describe why protons can be of benefit. So I'm showing here a very classic example of a skull base chordoma. Again, these are very treatment-resistant tumors that require very high doses of radiation. And as we can see, they occur in very critical locations next to the brainstem, the temporal lobe, the optic structures, and really the ability of protons to deliver in a very critical location. We're not able to achieve these kind of similar dose constraints with the photon plan. But again, these tumors are relatively rare, and we do know that this improvement in local control does mirror overall survival. And again, patient-reported outcomes, which is really essential, patients' ability to continue to function and return to work, are all kind of very important, I'll call it outcome measures that can show benefits. It's very hard to show kind of survival benefits in many of these types of cancers, but certainly in terms of similar to IMRT, we do show a reduction in toxicity. So again, why is it so challenging to enroll or to run formal phase 2 or 3 clinical trials? And I'll show you some examples because we have completed some recent clinical trials. But again, just the cost, the slow accrual, this really changing field where the technological advances really change even throughout that course of the clinical trial. So again, it's become much more, at least we want to show in every single patient that we can use their information to improve our research and develop in protons. And this Dutch modeling based approaches where we can extrapolate a DVH dosimetric comparison to late cardiac events where we're not waiting 10 to 15 years to be able to show the outcome of a clinical trial. And we can actually incorporate a patient's age and their own clinical history to have a very clear benefit in a particular patient. So again, I'm just showcasing several randomized trials that have been recently completed. One is the phase 2/3 trial that is in head and neck cancer, with the goal of reducing morbidity and quality of life, and the diffuse glioma trial, trying to preserve neurocognitive function in these are young, highly functional patients. And again, I'm also showcasing 2 other trials that have been ongoing and still need to meet accrual. So again, as I'm showing in this slide, you can see that many of these trials have taken many months, and the average accrual is quite slow. And also, there are significant technology changes that have occurred during that length of the trial. So for example, for this liver trial, I'm going to show you an example. Again, the proportion of patients receiving IMPT is only 1/4 of those cases. So again, this is the trial for diffuse gliomas. So these are young patients who have a long survival. And many times, once they've given chemo and radiation, they have really devastating long-term complications or have poor memories and are unable to work or take care of their families. So these types of trials are very important. I do want to kind of showcase that other endpoints that are very important include the effect of conventional radiation on the tumor microenvironment. So in gliomas, again, using photon therapy, we do see an effect on cancer cells. We also see a very immunosuppressive environment that really negates any potential benefit for future therapies, including immunotherapies. But we have shown that this can be, that charged particles, because it has less impact, actually is not only more beneficial to hypoxic and these very treatment-resistant stem cells, but they can really have less of an impact on microglia and allow for more combinations with immunotherapy, which can be very important in additional types of cancers. So I just also want to share some of the flip side, and this is where registries and being able to share our data among institutions has been so essential, and that there is really a very steep learning curve, that protons is not just more conformal photons. And this addresses many of the patients that we follow. So all of these patients were followed with imaging every 2 to 3 months. None of these patients were re-irradiation cases. And I'm just showing you an example of a patient who at 40 was completely asymptomatic, had a post-op MR scan, and very classic to protons, had a very punctate enhancement in the periventricular area. And this patient was followed, and 4 months later was admitted to the emergency room with seizures and significant weakness. Patient was treated with high-dose steroids with improvement of the symptoms. But again, this awareness of the imaging changes and the ability to treat right away is really an essential part of taking care of patients who receive proton therapy. And again, there were patients that received that showed treatment-related imaging changes. 4 of them developed symptomatic radiation necrosis. And again, this typically occurs earlier than changes that we might see with photon therapy. And just showing you just patients that were symptomatic, the therapies that were required. Many patients responded simply to steroids. And again, these are patients that are caught early and treated early. Hyperbaric oxygen or other types of therapies, including Avastin, are needed. And it's really important because this can be a significant morbidity and mortality. So again, in many of these series now, we show that this is not related simply to an LET or an RAB effect, that this is really an individual effect where the patient itself and the volume of a normal brain that's treated, as well as other factors, including number of surgeries or concurrent chemotherapy, can add to this. And again, being able to develop strategies to be able to reduce these treatment-related effects and identifying patients at high risk are really important. So again, I just want to showcase here at McGill that with advanced imaging, including PET or MR, we have the capability of looking at these changes very early in a patient's course, be able to predict these changes as early as 2 to 3 weeks during their course of treatment. So just one other kind of example in the CNS, where there's been some preliminary data and now a newly opened clinical trial. It's a phase 2 trial of Proton cranial spinal. So this is an example of that compared to these photon plans, where it is really challenging for patients with very limited treatment options, and they're not able to tolerate this type of treatment, that we have been able to show a preliminary benefit in a small number of patients in breast and lung cancer with leptomeningeal disease. So we look forward to helping to enroll in the study to demonstrate a potential new role of radiation therapy. So I'm going to switch gears and talk about a very few kind of different examples where here in the head and neck, we treat many patients with concurrent chemoradiation. Many patients have a significant weight loss and require a feeding tube in order for them to get through their treatment. But with the use of proton therapy, it can significantly reduce the normal the tissue radiation, especially in areas of the oral cavity. So this is a patient's ability to taste. And many of our Quebec patients almost will refuse therapy because of some of these dry mouth and taste changes that can occur. So again, this ability to improve patients' quality of life is a really important advancement. So again, this is a recently completed trial that will compare IMPT to IMRT, where it's really looking at reduction of morbidity, quality of life, and really patients' ability to return to work and to be able to highly function. So these PROs are an essential part of this study. But on the flip side, I think it is very important to also showcase the many issues with pencil beam or scanning proton plans, and that now with online adaptive therapy, just like in photon treatment, in protons, it has also become something that is really key and important. In many of these oropharyngeal cancers, patients have a significant reduction in their tumor as early as 2 to 3 weeks, where 50% of the tumor can shrink. And all of a sudden, these very high doses of radiation, including protons, are in these normal tissues. So again, frequent imaging and adaptive replanning are needed. And there is a real need for biologically corrected cumulative dose distributions to really know what the patient has delivered, because this has significant impacts in terms of causing significant toxicity as well. So another area that I just want to showcase our particular physics group, including with novel PET tracers of hypoxia, as well as FDG PET in terms of showing tumor uptake, but also other, I'll say, multi-parametric imaging that can really help us showcase what is the most resistant areas that we can potentially provide additional proton or photon boosts to. And that includes cellularity, looking at areas of low ADC and low perfusion. So I'm going to just kind of run through a couple of areas where we have seen clinically a real improvement in new indications where patients would have no alternative treatment options. And I'll say liver cancer is one of them, where there are very few treatments. And many of these patients have very diseased or cirrhotic livers, where photon plans are not possible because of the significant dose to the rest of the function of the liver. But because these very large tumors are not good candidates for SBRT or other types of treatment, now that we have repainting and gating and breath holds, we have been able to create these really high quality proton plans. And so again, the current phase 2/3 trial will look at improving overall survival. Many of these patients do not have IMPT plans. And so again, a lot of this kind of change in technology is something that we'll have to review carefully. But there are also very novel translational studies, including hepatic growth factor, that are important biomarkers that may suggest which patients may benefit from proton treatment or have less toxicity. Again, an area that is very important to our institution is we see a lot of young women with breast cancer patients who have concurrent systemic therapies with significant cardiac risk because of their left-sided tumor that requires nodal irradiation. There are patients with genetic concerns or even mobility concerns where photons are not possible, and protons can provide a significant advantage. And so again, many of these pragmatic trials have really helped increase the opportunity of patients to receive proton therapy, and these trials are accruing extremely well. So I'm going to kind of switch gears in terms of areas where tumors require motion management. In esophagus cancer, it has really been also a game changer in the fact that many patients receive concurrent chemoradiation. Many patients are elderly and receiving radiation treatments in a very critical location where the heart, the lungs, spinal cord are all in this region, and it can help reduce the 90-day post-op morbidity. Again, these trials are not always easy, and some of these smaller trials have actually shown only a difference, especially for well-selected patients. So as we discussed, one of the many advantages is not simply reducing toxicity, but in order to improve outcomes by having less damage to our surrounding microenvironment, that we can allow for less, we can combine chemoradiation in a much more successful way by reducing its impact hematologically as well. So there are less patients being admitted and having significant toxicity. So one area that has a lot of buzz has been lung cancer, and you can imagine that this is probably one of the sites that you would least likely want to start off having a proton trial. And I think these are things to kind of keep in mind, and we really look forward to the trials that have just been completed. So this is an example of an IMIT plan. Again, many of these patients now receive immunotherapy, and so this advantage of treating less normal tissue, especially if they're also receiving concurrent systemic therapies where the bone marrow effect is really important. It's in a very critical spot, including heart, and there are a lot of heterogeneities. And so many of these trials, again, the thought is that it may help to reduce the toxicities. So as we just pointed out, not only lymphopenia, but also cardiac toxicities. And again, these comparisons of, I'll kind of repeat myself, but these really steep learning curves. Most of these plans in the beginning were passive scattered, and again, having very large margins to account for patient motion and heterogeneity, and have really created very poor initial proton plans. But now that we have optimized beam weights, beam directions that can really help mitigate some of these uncertainties, the toxicities of the later patient proton cohorts were much improved. So again, there are a lot of study design flaws in these initial trials with very nascent proton planning. And now that IMPT is fairly standard and the technology's improved, but also planning techniques have improved, all of this will hopefully help to level many of the playing field of some of these initial difficulties that we noted. So again, IMPT is great for tumors that do not move, but it creates a much greater issue for those with uncertainties, with anatomic variations, with change in tumor that we often see, but especially with tumor shrinkage. Again, this online adaptive replanning is essential, not only for the head and neck tumors that I showed. So it does provide better conformality for tumors that don't move, but it is certainly much more sensitive to anatomy changes, and certainly being able to give shorter treatments. All of this with increased beam transmission has really been a game changer. And now that we can achieve very quick cone beam CTs, gatings, and breath holds, it really allows us to do things that we were not able to do previously. And again, I can't overemphasize how important replanning is for many of the toxicities that were seen in the past. Again, especially in the nasal cavity, where all of these changes can lead to a significant change in dose and toxicities to your optic structures, these significant weight changes and change in body contours, this abdominal variations that we've noted. And this tumor shrinkage is really a significant issue, both in oropharyngeal head and neck cancers. And again, many of these issues are things that we now recognize and are better equipped to deal with. So again, in summary, protons is being evaluated in many clinical trial consortiums. There are trials in our 3 most common cancers, and we eagerly await these results. But we really do need to work as a community to really show the comparative value. And this may not be in these kind of standard clinical endpoints that we have noted in the past. again, there are significant challenges that remain in proton radiation therapy. And again, in many centers, initially, most of the data that we now have to show to governments to approve protons are really showing immature proton technology and techniques. We now recognize that there's much greater sensitivity to this inter and intrafractional anatomy changes in motion and setup. We know that there is a significant variability of RBE, that it's not simply 1.1 of photons. And many of these trial designs have shortcomings that these newer generation trials have tried to overcome. But there are solutions, and I think this is where it is such an exciting time now that being kind of early to the proton game, similar to cell phones, has been advantageous. It really is an interesting era now that with our computational ability to provide plans in a very rapid fashion. So again, including with carbon ion, where it took 20 hours plus to see a optimized plan, where now you can do this in kind of 15, 30 minutes. It really is, I'll call it kind of game changing to clinicians, having Monte Carlo based cumulative dose distributions, being able to optimize on LET, and being able to know that this variability in RBE is an important consideration that we can also exploit. And I'll talk just briefly about some of these biological uncertainties, and certainly I can share with you that it's been really essential to have these in-room cone beam CT on a very rapid basis. As you can see, the quality is improved significantly, and being able to do gating is a really important advancement in many of these. So I think as a group, we've all recognized that RBE is a very complex function, and we certainly know that it really is very dependent on tissue type as well as function size. It's not a one size fits all, and it's the clinical endpoint that is observed is a very important part of this. And essentially, in all IMPT plans now, this ability to do robust optimization so that we can optimize for not only LET, but also in terms of these uncertainty scenarios, not limited just to patient setup or motion. And this robustness certainly that we see with single fields, but is really especially important in multi-field optimization. So again, being able to generate these worst case scenarios really allows a physician to know what is the likelihood of tumor coverage, but also in terms of predicting toxicity. So all of these tools are very important as a physician decides and chooses between an optimal plan. And I really feel that these knowledge-based, that it's not really dependent on the experience of the institution, but having this catalog and being able to select for the patient that is in front of us, what is the best plan will be really an important part of improving the workflow and ensuring that patients who would benefit from protons can receive it in a timely fashion. So again, I suggest that despite this significant increase in number of proton centers, the number of patients that would benefit from protons has significant increase from this slide. There's about 400,000 patients per year that receive protons, but there are also 10 million patients that receive radiation on an annual basis. So again, as a community, we certainly hope in our future directions that we can help improve our image-guided proton therapy and really make online adaptive treatment a ordinary workflow, and that it allow us to really look at novel treatment combinations and really exploit the value of protons that we're just kind of scratching the surface at. So I hope that I've convinced you that protons are different. They come with a substantial learning curve, but they have great unrealized potential as part of the armamentum of cancer treatments that we offer to our patients. It's really critical that we design pragmatic and innovative clinical trials that can accrue in a timely fashion, and that the old kind of clinical trial designs are really not allowing us to demonstrate the pressing need of proton therapy in particular patients. So I'm just going to stop sharing, and I'm really be happy to answer any questions that you might have.
Hey, I wasn't sure. Do you want to come out from behind the curtain and
Oh,
answer questions?
I think I'll just kind of, but I'm really happy to answer any questions and,
Moderate.
interact with,
So
providing some.
questions online, as always,
Okay, great.
if you don't want to say your question out loud, type it into the chat and I'll read it out loud. Mirta, go ahead.
Yeah, well, thank you so much for this wonderful, comprehensive talk. It was just so informative. So thank you, first of all. I have a question regarding the RBE and, the variable RBE for proton therapy and RBE being relative to photons for the different primary locations for the tumor, let's say for prostate, where patients sometimes receive external beam 6 megavolt and also maybe some brachy boost. How do you see that going forward? How can we actually, have that variable RBE plan better for the future of particle therapy? I mean, in this case, proton therapy, and not having 1.1 all the time.
I think we really have I think that was the biggest hurdle. I think that there's so few proton centers there now that there's this kind of, I'll call it exponential increase. And many of those initial centers are really financially driven, that they didn't have the ability to really explore all of this, I'll call it the biological impact. And the problem is that it's so related to each tumor type, as you say.
Yes.
Right? If you try to say this in prostate cancer or in brain, where we saw a lot of these issues in the brain stem, and if you kind of have a one size fits all, I think that's where this recognition that each particular clinical outcome and the tumor type and even the type of therapy, all of that really makes a substantial difference. Some people really feel, again, that we can also exploit this, that this kind of variable RBE in this spread out Bragg peak, that as we increase the LET, as the protons in this decreased at the distal end of the Bragg peak, this kind of is something that if we can optimize that, we can actually use it to our advantage, so that we can actually increase the tumor control. So I think these are all things that we're trying to include and add. And I'll say that a big shout out to Race Station that has really given us this opportunity to be able to create these kind of optimized LET plans so that we can look at them and then also be able to measure what the patient's outcome. So I think all of these kind of registry information is really, because even as we model it, even as our ability to model this, we really need it in our patient environment to actually know how it works. So I think it's a very complex question, but I think we are really in a very good shape now that we have the tools. I think we understood the concepts, but we didn't have the tools, and now we have the capability of combining all of that. So it's because of folks like you that we are going to make progress now.
Thank you. Thank you.
Great. Other questions? Morgan, please go ahead.
Thank you for the really nice talk. I was wondering what your perspective is on fixed beam facilities, because on one hand, it reduces the cost, but on the other hand, you don't necessarily benefit from a lot of the advancements that are happening in terms of, say, multi-directional beam delivery and that kind of thing. So I was just interested on your thoughts there.
I think that boat has sailed. I think if you think about it, with carbon ions and things, and we're talking about fixed beam, you really need to be able to get the dose to the patient. And those initial fixed beams were really, I'll say again, without our ability to do a conformal plan, you'll be very disappointed and say, why is protons not better? So I estimate that one of the things that has changed the most, that has really led to this, I'll call it exponential increase, is this idea of a single room. So that, in fact, the number of patients that would benefit protons is actually much smaller than you think. but being able to give the type of plan that the patient requires in a complex situation is probably the most important. So those costs have all significantly decreased. When we, it took over 10 to 15 years to get a Proton approval. It was like 250 million, and that cost went down, significantly. And now even, I'll call it, these are kind of in a 25 to 30 million range, you can have a Proton center with a rotating gantry that can provide the kind of plans that you need. So I do think that there are, it might be that places in Africa or what I'll call it Halcyon is a good example where we do find a kind of low-cost solution. But I think in a place like a G8 country, we still need a capability of delivering, I'll call, state-of-the-art protons. That's just my take.
Thank you.
Questions from the room? I had one on deck. Oh, hold on, Sharon has one. Let her go first. Go ahead, Sharon.
Yeah, thank you, Christina, for this very interesting presentation. So then my question is, when do you think we can have this state-of-art center in Canada?
I am so, well, now that Edmonton, now that we can say that Canada will have one site, I think that will open the door, because it really is financially kind of insane, the amount of money that is spent to send our patients to the US, that we are buying all the Proton centers for the US centers. Like we've personally funded the new upgrade at the MGH. I think, again, it just makes economic sense. And it's really, I'll say it on a patient level. When you're a pediatric patient, many patients, when a Proton center, a single room center is open in a community, it really allows a young patient to be able to receive the cancer care that they need in the environment that they need among their family, and that they're not, it's quite traumatic to have to be away for that long kind of period of time. So I think that we are in this kind of golden era where I think that it really is something. We were very close. We almost had a single room Proton. And I think that this is something, again, that if we kind of provide the data, this is a bit of the purpose of this talk.
Yeah, well, thank you so much.
Well, I look forward to working with, I think McGill is a really essential place for us, because it's really, you recognize you not only need the clinical expertise, you need the physics expertise. I cannot tell you that we were able to do many things very safely because we had physicists who were 10 to 12 years of experience with protons right off the bat, but we had all these scientists. So we had these students, everyone who was doing experiments. It is a kind of a research, it just improves our programs. I'll call it our lung programs, our ability to work with our medical oncology colleagues to provide new and novel therapies. It is really a place where our McGill community, our scientists, our basic scientists, our students would really, I'll say, have a significant impact on the scientific community at large.
Great. So I did have one question myself. We had one slide on the tumor microenvironment and how there were differences of heavy ions versus protons. I mean, it's very interesting. Is that understood why that's the case, or is it still something we're not too sure about?
No, it really, we showed actually some many clinical trials, and it's really nice to show that the preclinical data matches our clinical experience, and that in many of these trials where immunotherapy is combined with radiation, we see no effect. And the reason why is because of all of this radiation is very immunosuppressive. We're affecting vessels, we always have this idea that we're just affecting tumor, or affecting the vasculature, so all of this, I'll call it M2 macrophages, are affected by our photon treatment. And we don't have that footprint when we give charged particle therapy. And so that mirrors that and gives us an opportunity where it's not just chemotherapy, but potentially radiation may be something that can be combined.
So it's more to do with the dose distribution and not the fact that they have higher LAT.
Well, again, these are all things that we do know that there are differences in protein expression that has been noted as well. So it could be many factors, not just one, but.
Okay. Super, thanks. Right, last chance for questions. Otherwise, we can thank Dr. Tsien for a very interesting talk, and thanks you all for.
Hope we get Proton soon.
Yeah, good luck with them. Well, if there's a small group of McGill students working on a compact proton accelerator, maybe that'll work out. That'd be good. All right.
Fantastic.
Thank you, everyone.